Welcome back, everybody, to another rousing episode of Medics, Musings, and Mayhem. I am one of your hosts, Dr. David Collins, Medical Director for the Sticks of Minnesota and South Dakota, and with me I have Regan.
It's always good to be back.
Regan, what are we talking about today?
Today we are talking about some trauma. And since we have that
season.
Summer season, we have the summer season coming up, at least in the Northern Hemisphere, and that's when all of the trauma likes to come out. So we have a nice overview of trauma right now, and then we'll get into some little kind of more specific trauma scenarios throughout the rest of the summer.
Yeah, our goal here is that we're going to set everybody up with the typical approach of how rural EMS should consider trauma in both like a BLS and ALS setting. But we also want to give you some smaller scenarios that you can think through in a much quicker fashion compared to our typical 30 to 45 minute talks. So look forward to these next couple podcasts where we're going to be spending about 15, 20 minutes on a traumatic event of some kind. And Regan and I will then work through how we might approach it and what some limitations could be coming up. We're going to do our typical spiel or our typical scenario first, talk a little bit about pathophys, walk through protocols, and talk a little bit about the evidence-based medicine, which when we talk about rural EMS trauma, there's not much. So we're going to have to talk a little bit more broad in that sense. But the more we can educate ourselves on how to do trauma well, the better. Regan, you got your EMS hat on?
I got my EMS hat on.
Okay, page is going out. You hear that there is a 35-year-old male who was caught in some sort of gas explosion, and the severity of their injuries are unknown.
Well, as a typical EMS personnel, the first thing running through my head is this scene actually safe for us to enter? I mean, we hear gas explosion, and that's not something I want to go running headfirst in with my crew and all my gear just to become patients ourselves.
Yeah, gas explosion is a little vague, so obviously we'll want a little bit more context before you roll into the scene, and scene safety is very important. So for the sake of brevity, we'll say that law enforcement is already there, and contextually, this is a bonfire that went out of control. So from what you can tell from your colleagues in your first responders and law enforcement is that the scene is safe.
All right, then we're going to be rolling up, still keeping an eye out for any changes to the scene, because a lot of these explosion, fire scenarios can actually change a lot when you're on the scene. But as we arrive up to our patient, you want to let me know what I'm seeing?
Yeah, on arrival, looking around, you do find your patient. You observe an adult male. There appears to be second and third degree burns involving the face, chest, and torso. His clothing, especially his shirt, is melted to his body, and you hear some stridulous breath sounds, and he's unable to speak in full sentences.
So already know that we got a pretty critical patient here. First things first, as we're rolling through any sort of case, we're looking at those big three, that airway, breathing, and circulation. Knowing that we also have a trauma, in this case, we're adding some things like hemorrhage and head movement, and we'll talk about that when we get towards the protocol. But first things first, do I see any massive bleeding going on?
Massive bleeding, you don't really see bleeding per se, but you do see multiple burns over the skin, but nothing that seems to be oozing or spurting.
Then I'm moving on to my airway. You've already told me we're unable to speak in full sentences. We're probably going towards respiratory failure. I will likely have my partner or myself start getting some intubation equipment set up while I finish looking through and chatting with the patient, if I can.
Which is not much in this case, but we'll continue through your little mnemonic and then we'll come back to that.
So then I'm hearing for any sort of breathing abnormalities, which you've demonstrated for me, and if those are even happening on both sides of the chest.
From a respir's perspective, you see even chest rise bilaterally, though the landmarks are severely charred and burned, so you can't really tell. Plus, keep in mind the t-shirt is melted on. When you listen to the breath sounds themselves, there's probably some degree of, maybe, shall we say, like wheezing to it, or maybe just some extra noise that you wouldn't necessarily expect when you're listening for normal lung sounds in that case.
And keeping in mind that I'm getting my intubation equipment as we're going, that also is supporting this decision. I know we're not having good respiratory flow. We don't have a great airway either. Let's see how our circulation is doing. Since we have burns clearly visible on the chest, our perfusion probably isn't great, but I'm still checking our toes, our fingers, anything that I can see that we still have some proper circulation going, given that I know we don't have a massive hemorrhage.
Yeah, so circulation wise, yeah, the upper extremities are pretty much all involved at this point. So there's not really a great space for cap refill, but you do check the toes. Toes got circulation. Pulses are strong from where you can tell, but very limited in terms of assessment for the upper extremities at this time.
And my last thing that I'm keeping in the front of my mind is any head injury. I know it's a gas explosion. That means my patient was thrown. Did they have any injury to their head or C-spine that needs to be taken into consideration while I'm getting that intubation done?
So examining the scalp area and whatnot, you don't appreciate any lacerations. There might be some abrasions over the scalp, no active bleeding. Again, this patient seems to be following basic commands, but very clearly in extremis due to the fact that their airway seems to be getting compromised.
And like we said when we first came onto that scene, I'm making sure that it's safe. As I'm assessing my patient, I'm also monitoring for any changes in that environment. And I know that I got a pretty critical patient here, so I'm going to start my interventions like that intubation, getting them breathing under our control and kind of getting them out of that area as well. It does sound slow when we're talking about this, but when we're actually on scenes, this is all going through our heads very quickly, and the actions are happening a lot sooner than us sitting and talking about it step by step.
Right. This is something that we call high acuity rare occurrence. And so the more we can have a protocol or a mnemonic in our heads, the less likely we're going to get the deer in the headlights phenomenon, which is common for all of us. Like no one is perfect in that regard. But by having something like the Marches mnemonic, which we'll unpack later, this helps you to stay focused on what's going to kill the patient now so you can get them to definitive care. You've done your primary survey, Regan. Would you like some vital signs?
I would love some vital signs.
So your partner is working very quickly beside you and obtains the following vitals. Heart rate is 130 in that range. Blood pressure is currently 90/60. O2 sats are 85%. And their respers are roughly 30 to 35.
So we have a tachycardic and tachypnic patient that's also hypotensive and doesn't have a lot of oxygen going around, so they're a little hypoxic. A wonderful combination of vitals that's also just solidifying the fact that we need to get some interventions going and get on our way.
Totally agree. Anything you want to know about your secondary assessment while your partner is helping you?
When we're talking about burns and trauma that comes with any sort of burns or gas explosions, airway is the first in our mind. And I know we already don't have a patient who can talk to us appropriately, but I'd want to reassess the mouth again, see if there's any obvious inhalation injuries, any swelling to that area, anything that's going to make that intubation a little bit more difficult, and see if I need to have additional tools by my side.
Sure. So in terms of the HNT perspective, you do note that the nasal hairs are singed, the oropharynx has soot in it, and there is probably a little bit of pharyngeal edema developing as well.
All things to consider and have our team go a little bit more urgently towards that intubation. Additionally, we know that there are burns going on across the body. I'd want to characterize it just a little bit more, see if we have anything melted into them, any foreign bodies there, and an estimation of that total body surface area, which will help with our fluid resuscitation.
Right. And we can talk about the math at a later date. But for the sake of brevity right now, you do notice that this patient has full thickness burns to the face. Their eyebrows are singed. We talked about the soot in the oropharynx and the nasal hairs are singed. There are partial to full thickness burns involving the torso with the t-shirt melted to the body like we talked about. There's also some partial thickness burns to the upper extremities. When you get to the lower extremities, thankfully, it seems that their genes have spared them for most of it. There's some maybe first-degree burns or some superficial burns present, but nothing that appears as concerning as the trunk and the upper extremities. There's a lot more nuance to burn, so we'll have an entire topic devoted to this at a later date so we can talk about burn assessment percentages, what type of burns there are, and all that good stuff. We have our scenario. This is very high anxiety inducing, which is the whole goal of this. We want to talk about worst case scenarios so we can process through the entire algorithm so we can make good, rapid decisions that will not delay care and get them to a higher level of care, whether that is getting them down the road to the nearest hospital or if there's a helicopter in the air because this is a traumatic event and it's going to be fastest to fly them to the nearest facility. So why don't we transition to talking a little bit about the pathophysiology? Regan, why don't you unpack a little bit? When we talk about what will kill the patient first, let's talk a little bit about what marches means and how that relates to the pathophysiology in the context of trauma in general.
So a common mnemonic that is used in EMS, trauma, emergency departments is marches. And the order of marches goes from time to death from seconds to minutes to hours. It's all very acute, but you want to catch the things that are going to kill the patient the fastest so that you can fix those quickly and keep our patients alive throughout these traumatic experiences. So when we're talking about marches, the M stands for massive hemorrhage. If we have any sort of artery or any sort of major bleeding going on, a patient can bleed out in seconds to minutes. Normally, when we're going up to a patient, airway is the first thing on our mind, but airway has a time to death of minutes. Bleeding out can go a lot faster than not having an airway. So with that M in marches, massive hemorrhage, we want to see if there's any sort of arterial splurting, venous drainage, loss of a limb, anything that can have direct pressure or a tourniquet placed on it to stop that bleeding right away. With that pathophys of a hemorrhage, it's pretty simple, along with a lot of the other things in a trauma scenario. But if we're losing all of our blood, losing that intravascular fluid, our heart isn't going to be able to pump anything through our vessels. Nothing is going to get oxygen to it. We're going to have a compensatory rise in our vascular resistance, in our heart rate. We're going to overwork ourselves, which is also just going to push more fluid out unless that bleeding can be stopped so we can keep something in our vasculature and also can be topped off with fluids and blood. But of course, that's not happening right in the field. So you got to stop that bleeding first.
A lot of our trauma research is based more on battlefield medicine rather than it is in civilian life. We generally don't have a lot of traumatic wounds or injuries, or at least not the volume that you would expect in armed conflict. So a lot of what we learn in terms of how to rapidly assess a patient and how to fix them or to reverse causes is from what we see in the battlefield. Another example of this that we will likely see in the near future is the return of whole blood in terms of transfusions for patients, because there's been studies showing that this could be more effective than what we currently do with the massive transfusion protocols. This is one of the reasons why armed conflict has helped us learn a lot about the human body and how to rapidly reverse causes, and massive hemorrhage is the thing that will kill the patient the fastest, just due to the fact that if you run out of vascular supply, you no longer have a way for oxygen to bind, and then you will die very quickly.
The next thing we have on our marches mnemonic is airway. So this can kill a patient within minutes. If we don't have an airway, we have no air movement, we have no oxygenation, and our tissues are not going to work. After our airway, we have respiration or breathing. Again, we have that airway set now. We need to make sure that we actually have air flowing. So things that we want to be checking out for, is there like a pneumothorax? Can happen commonly in trauma scenarios where we don't have one of our lungs working for us. And on top of that, we can have increased pressure within our chest cavity that can cause decreased venous return to the heart. We're not going to get blood pumped everywhere, and we're going to affect our cardiac output. So again, respirations can come all the way back towards an airway or towards a hemorrhage like pathophys. If we keep working through those steps of it, we're going to fix problems that aren't going to cause other problems as well.
And it's important to keep in mind that not only can pneumothorax lead to increased intrathoracic pressure, but a hemopneumothorax or a hemothorax can do that as well. So keep in mind that sometimes hemorrhage, airway, and respiratory can all be linked together as well.
The next one on the March mnemonic is circulation, and this fits in well with what we just said. If we don't have good circulation, good blood flow, not from the hemorrhage that we've already fixed, not from the oxygenation that we're taking care of, we actually just don't have good circulation, whether it be blunt cardiac trauma or we have limb ischemia and we don't have good circulation in one structure, or a crush injury causing a loss of that fluid into that specific region of the body. We want to make sure we can get some circulation in there, whether we're starting some fluids, releasing tight clothing, putting the patient into proper positioning, anything we can do to make sure that the body is working the best it can.
And hemorrhagic shock would be another example of where circulation could become impaired. So again, keep in mind that all of these are very intimately linked. It's just more important to remember that this is all designed just to kind of keep the deer out of the headlights phenomenon in order to provide the best care we can for the patient in the field in as little time as possible.
Next up on the march, mnemonic is the H for head injury. This can usually take a little bit longer for a time to death, but it's something that we keep in mind early on, because if we don't have a brain or nervous system helping the body out, we don't have a lot of control. So things that can cause trauma to that head, to that spinal cord, is going to affect the rest of our body. Things like hypotension, bradycardia, vasodilation are a common textbook picture. But really, when we have any sort of neurologic shock, kind of anything can happen. So we want to keep in mind that we stabilize our C-spine injuries, we assess for any sort of cerebral hemorrhage, checking pupils there, and noting that in these traumatic scenarios, because of neurologic dysfunction, we might have some increased responses to certain procedures, such as the intubation we were planning in that case. And just keep in mind that we might see variations to a heart rate or a blood pressure that we might not expect.
Bottom line is that the brain is the control center of all things related to the human body. So if that gets messed up, things like vascular tone get impacted, the rate gets impacted for the heart. There's a variety of things that can happen in the brain with traumatic injury that can then cause a variety of problems in the field. So you do need to keep your eyes and ears open for anything that does seem off and quickly assess and reverse what you can. Obviously, the brain is very restricted in the sense that we can't really do much for it in the field, but you can certainly start to identify things that could threaten the patient, and we can unpack that more later.
So some will see just march as the mnemonic, some will see marches, so that ES comes to it. So we'll talk about those here in the podcast, but that E is for environment. Things like hyperthermia, hypothermia, any sort of intoxication or burns like what we have in this case can have dramatic effects on the body as well. A massive release of cytokines or inflammatory markers, basically things just telling the body it's time to freak out, can cause things like increased vascular permeability, blood's going where it shouldn't be, loss of fluid into interstitial spaces. That would be things like edema if our legs or arms start swelling, and those can lead to a hypovolemic shock, even though there's not an obvious exit of blood from the body. Additionally, in the burns case, like we have evaporative fluid loss from all that exposure that the burns have caused. This can additionally cause hypothermia and a more dramatic dehydration than what we would initially think. We're also going to have things like muscle damage or hemolysis, basically breakdown of our blood. And we want to make sure that we have all of this in our mind, not only to properly transport to the correct facilities, but to initiate those shock measures a little bit earlier, keeping our patients warm, keeping them covered, keeping them in proper positioning, and making sure we're getting some oxygen on them earlier rather than later. The last thing we have in that march's mnemonic is S for shock. We've really already talked about the different shocks that can happen in these trauma cases. We have some hypovolemic shocks, things that happen after those massive hemorrhages. Cardiogenic shocks, if we get into a motor vehicle crash and we hit that steering wheel right in our chest, our heart can be damaged and not have proper circulation, like the C in our marches. We can have things like obstructive shock if we have any sort of crush injury, muscle breakdown. Any sort of shock can be happening in these trauma scenarios. So keeping those in mind, we need some fluids on there. And again, we need to just keep our patients covered, well hydrated, and get those emergent transports going to proper facilities.
The other thing to keep in mind, especially if you're in the pre-hospital setting, is that there can be polyshock. Don't always assume that the trauma led to the shock. There are situations where a patient is septic from a UTI or from a pneumonia and they go into a ditch because they lose consciousness. So all of a sudden you've got a distributive shock with an infection, plus you might have hemorrhagic shock because now their spleen is lacerated and they're hemorrhaging into their abdomen. So we do have to keep an open mind that not all shock is created equal, and sometimes more than one shock can exist at once. So this is important to also keep in the back of your head. Again, the whole purpose of having mnemonics like this is that we want to keep it as simple and as painless as possible. Because when you're in the moment with one patient, or if this is a polytrauma or a mass casualty event, you suddenly have 10, 15, 20 patients, and this is going to get very overwhelming very quickly. So by being able to go back to your basics and remind yourself of the March mnemonic, you can quickly get through these patients one by one rather than just trying to eyeball as best you can. So we talked a little bit about pathophys in the context of trauma and what can kill a patient quickly, but we should probably take a little bit of time to walk through each one and talk specifically about how we might manage these in the field. I really want to hammer this March's mnemonic home because this needs to become second nature for us. And I would argue that even outside the context of trauma, March's is still very relevant. So, this can be utilized in any patient assessment. It's part of why it's become more prominent in both pre-hospital medicine and in the emergency medicine world in the United States.
So running through our treatment options, first and foremost, we have that massive hemorrhage, that M of March's. We're going to visualize across the entire patient, and that probably includes log rolling them as well with proper C-spine precautions to see if there's any obvious hemorrhage going on that can be stopped. We're thinking here direct pressure, hemostatic gauze, or even a tourniquet if needed. These are all very quick things that we can do in the field. We even practice doing these early in our training and refresh ourselves often because we need to stop these hemorrhages as quickly as we can upon noticing them.
And I would add, we have campaigns out in the US now, including the Stop the Bleed campaign. Super helpful for those of you that have never done it before. So if you have that in your community or in your area, I highly encourage you to take the course at least once, because once you're trained in how to do it, you can teach others and you can do a better job of stopping the bleed.
Next in our March's mnemonic is that airway. We're assessing for our airway patency, seeing if our patient can even respond to our questions. And we're also looking for any injuries that can affect our airway, such as facial fractures, hematomas to the face, any sort of blood or vomitus in the airway, burns or inhalation injuries like we had in the case today. And we want to make sure we're taking those next steps in airway management. Whether we're putting in just a simple adjunct or we're starting to move towards our intubation, if we might not have time for that extensive of a procedure, we can always do things like a supraglottal airway, easy enough to put in. They have that airway protected now, and we'll be able to move on to our next step.
When it comes to the supraglottic airways, the most common one these days is the iGel. But I would add that these are going to be in the context of a patient that is unconscious, unresponsive, because if they have a gag reflex, that's going to come right back out. If you want to learn more about rapid sequence intubation, I would strongly encourage those of you that have not listened to episode 4 to go to that, where we do touch this in depth in terms of how to adequately both sedate and paralyze the patient safely so you can have a successful intubation in the field. We'd want to avoid all intubations when we can, just because in the pre-hospital setting, the environment is not great. It's not the OR, it's not controlled. And obviously it can be a lot more chaotic just because there's more variables out in the pre-hospital setting than we have in either the hospital or the OR. But in the context where the airway has to be taken, please see episode 4 for RSI.
After we get that airway secure, it's not good enough just to have an airway there. We need to make sure we have proper breathing, proper respiration going. So we're assessing for our rate, for our pattern, any sort of tracheal deviation, any possible hemo or pneumothorax that we can fix in the field, any asymmetry of our chest wall movement, seeing if there's a flail chest there. And we want to listen bilaterally, making sure that we assess even as simple as just top and bottom bilaterally, see if we have some good breath sounds, or if we need to be moving to some needle decompressions, semi-occlusive dressings for the chest wounds, and what kind of oxygen we need to keep that greater than a 94% on our SpO2.
The other thing I've encouraged my paramedics to think about in the context of a really terrible trauma where the patient is very unstable, there's O2 sat derangements, there is flail chest, there, anything else that would suggest that the chest wall is injured severely. This is where we would discuss potentially a finger thoracotomy as well. But again, we'll discuss procedures more in the future when we start doing these quick hits in trauma.
The next one we have in our mnemonic is circulation. This is where we'll be assessing blood pressure, heart rate, getting a fuller sense of the vital signs. We also are assessing again for some hemorrhaging, but might be internally. seeing if we have a unstable pelvis that needs to be binded. We'll get some IV access. Usually 2 large bore IVs is what we constantly hear. Whatever you can get is amazing, especially in a lot of these trauma cases. Just get access any way that you can. Do not be afraid to use an IO if you can't get those IVs going, because fluid resuscitation is very important and we want to get that started in the field. Additionally, we've talked about having some blood products in the field. Different states have been having newer protocols, so keep an eye out for what you have in your area. But keep that in mind for these trauma cases, that maybe we get a liter of fluids in and we're moving right on to blood products before we even get into our emergency departments.
And this is going to be a more nuanced discussion too, just because smaller facilities and smaller ambulance services may not have blood products. So we're going to use what we have. And keep in mind that ATLS guidelines have changed since the 10th edition. In the past, it was discussed that we would do 2 liters before we went to blood products, but recommendations have now changed to 1 liter. The main reason being that if we truly have a patient that is hypotensive, a liter of fluid, if they are actively hemorrhaging, is probably not going to do much. Whereas if they're bleeding a little bit, a liter should be more than enough. Furthermore, if we are transporting a patient in the field, hopefully by the time that first liter is done, either the helicopter has come in or you're at your receiving facility now giving blood products. So that's the whole thought process of doing 1 liter and done. If, God forbid, that you're in a situation where it's a prolonged extrication and you don't have blood products, doing a 2nd liter is not wrong. There's just been some studies now showing that the faster we get the blood products, the better. But if you're trying to keep the patient alive, trying to keep them hemodynamically stable, you've got to do what you can with the resources you have.
Next in our marches mnemonic is a head injury. We have our airway, our patient is breathing, they have some circulation set up either with fluids or blood, they don't have any hemorrhages going on. Now we can assess their neurologic status. Things like getting a GCS or even just doing an AVPU, so alert, verbal, painful, unconscious, just to see how they're doing in this situation. We also want to assess their pupils, see if any sort of neurological deficits are present. Are they moving one side of their body and not? Are they responding when you pinch their right arm but not their left? Some of those things we want to notice. And of course, if we see any sort of posturing, keeping it in mind and maybe driving a little bit faster. Next, we have our environment. Things that can rapidly change in the field, in the rig, or anywhere are things like that temperature. We had burns with clothing on those burns. If it's easy to take off pieces, great. If not, don't touch it, but let's keep our patients covered, not only for a respect to that patient after doing our assessment, but because we don't want them to become hypothermic. Also in that environment, some things to note are just what is in the surroundings. Like in our case today, we came to this gas explosion. We're obviously very focused on treating that patient and getting them stabilized. We might not notice that the place is covered in empty bottles. Things that we want to know for when we transfer into our emergency departments and tell them, hey, we might be under the influence of X, Y, or Z, because that can affect those treatment options. The last thing we have on the marches mnemonic is shock. And usually with our shock treatment, we're already doing all of the other things from M through E. Additional things we want to keep in mind just for shock specifically: keeping the patient calm if they are conscious, keeping them in a position of comfort as long as their C-spine allows it, preventing any sort of heat loss, keeping that patient covered, and continuing to talk to our patients whether they are intubated or not. You have no idea what they're going to be hearing, and you might as well keep talking in a calm tone just in case.
I do want to briefly take a moment to talk about what one could do while in the rig en route to the hospital. So keep in mind that both Regan and myself are very pro point of care ultrasound. And so the more we can utilize it in the pre-hospital setting, the better. And this is a situation in particular where if you have the patient stabilized, you've done all your interventions that you can, and you still have a 10 or 15 minute arrival time, this is a time where you can start to assess further. Or if something were to change in the patient, we can start to further assess what's going on. So you can give your hospital a heads up as to what might be actively killing the patient. I want to throw out this teaser that we will be visiting with a special guest in the future to talk about what point of care ultrasound might look like in the pre-hospital setting. And this is a slightly heated topic when it comes to United States pre-hospital care. but we'll unpack that more and talk about what point of care ultrasound might look like in a pre-hospital setting, especially in the rural settings, and how that might be beneficial. So stay tuned in that regard. So let's talk a little bit about trauma activation, Regan. That is something I feel like that is really nuanced. Speaking as someone who went through emergency medicine residency training and working at a level 1 facility where you're in a big city, these trauma designations or these trauma activations are very common. And there's tends to be a much more nuanced approach in terms of they have tier 1, tier 2, tier 3 traumas. And you basically determine that based on mechanism, vital signs, and any other pertinent information that gets called in. That doesn't really apply to us necessarily in the more rural setting. Can you speak a little bit to what you heard when you were an EMT?
Back when I was an EMT, I worked both rural and urban service areas. So when I was in the urban area, any sort of trauma that we in the field designated as needing more resources in the emergency department, we were able to call a trauma activation into our hospitals. In the rural environment, it was a little hazier. The traumas can be a lot different than what you see in an urban environment, and they're kind of hospital specific. We would have some hospitals that would require any injury involving a vehicle, a large animal, or any sort of gun to be required as a trauma activation. The large animal one was always my favorite. But each hospital was slightly different. Some you could not call that trauma activation until you were in the garage. Some you could call it in the field. Some require that every trauma activation actually means a helicopter is coming either to you or to the rural facility. So it really does depend, and you just need to know what's in your service area and know that they might be a little bit different in each facility or under each medical director.
And in our case, that's what we would call an auto launch. So if there's any situation where there is a terrible trauma or first responders or law enforcement gets there and they deem it to be a bad trauma from their perspective, they will request auto launch. And that means the helicopter will be launched either from one of the other major cities, or we do have several independent groups in the vicinity that can also auto launch for us. But at the end of the day, we want to keep in mind that we want quick scene times. So if the helicopter is going to take 45 minutes and the patient is extracted and you've got them in the ambulance, you go to the nearest hospital, that helicopter can easily divert and land at your facility from there. So do not wait for a helicopter to get there. If they're 2 minutes out, that's one thing, but they're still 30 minutes away. You get to the nearest facility so you can get more help. More help means more ability to reverse life-threatening things, and you've got more access to resources. The other thing to keep in mind when it comes to these situations is we want to think about where should we transport a patient. And this gets more nuanced, especially when you live in more rural areas where sometimes the closest facility might be where the facility could be a level 4 or more of a rural designation, versus if you're closer to a level 1 and you've got a trauma, you might want to go towards the level 1. But what does that mean exactly? What does the delineations look like in the US? Typically, how we think about it is we've got trauma levels 1 through 4. The smaller the number, the more resources you effectively have. So your level 1 trauma centers are generally going to be your ivory tower hospitals that have all of the residency programs, as well as every single specialist you can think of. But the key things you want to think about is that they generally are going to have a neurosurgeon on staff 24/7. They've got a trauma surgeon on staff 24/7. They've got ICU services available, and they've got every other subspecialty that might be relevant to helping that patient survive the traumatic event. That is the main thing to keep in mind for level 1. Level 2 trauma designation, it still has a lot of similar overlap in terms that you're going to generally have the same specialists in terms of you're going to have a trauma expert, you're probably going to have a neurosurgical expert, but sometimes you just don't have the more nuanced specialties that may require that patient going from a level 2 to level 1 once they're stable. When we get down into the level 3 and level 4, that is generally more our audience when it comes to this podcast. A lot of people are going to be working primarily out of level 4s or critical access hospitals. The level 4 trauma designation basically says that you have a doctor that is either in-house or can get to the hospital in under 30 minutes, 24 hours a day. That is the bare minimum for a level 4 trauma designation, and that you've got the abilities to resuscitate and stabilize. Most rural facilities are expected to do that, especially when you don't have a hospital for 3 or 4 hours in a radius. So you've got to have some degree of ability to have a physician or a NP or a PA that's able to cover that ER, is able to resuscitate the patient and get them to definitive care. The difference between level 4 versus level 3 is basically that generally speaking, you're going to have some degree of additional specialty. So generally in that situation, you're going to probably have a general surgeon who might have some knowledge of their trauma days, or sometimes they might even have residents that come to that area to practice some rural surgery. I say that in quotes just because it's not truly rural in comparison to level 4 or the critical access hospitals. But again, you just have that extra specialty available in that level 3 designation versus a level 4. So where I practice most of the time, we are a level 4 designation, and that's going to be said about a lot of the critical access hospitals in rural Minnesota as well as South Dakota. You might see some level 3s when you get closer to the cities, and then your level 2 and level 1s are going to be, Sioux Falls, Fargo, the Twin Cities, whatever major city or metropolitan area that you're close to, that's going to be your level 1 and 2s. So before we go back to trying to save this patient's life from dumping gasoline on a fire pit, which is a poor life decision, let's talk a little bit in terms of evidence-based medicine from a rural trauma perspective. I'm going to be totally frank, and when you start looking for rural trauma studies in the literature, there is not a lot. So instead of really unpacking like very nuanced things, I thought we would start with something very simple, which we just talked about a little bit, is what do we define as a major trauma versus what do we define as a minor trauma? One of the studies that I looked at was a study in the British Paramedicine Journal, which was actually a very interesting read, published in 2019. And the title of the study was Defining Major Trauma, a Pre-Hospital Perspective Using Focus Groups. For those of us that have gone through med school, maybe some nursing school, and even paramedics hear about this a little bit, is that when we talk about the levels of reliability or the level of how strong studies are, this is going to be kind of more on the weaker side because a lot of what I'm going to talk about next is more of a subjective measure. There's a lot of PhDs in statistics as well as in economics and other areas that have tried to really master how to make subjective data more meaningful. They have developed techniques that do not necessarily alter the data, but maybe transforms it to become a little bit more objective in nature, and we'll unpack that more in a second. Basically, what this study did in the UK is that they asked the clinical question of how is a major trauma defined in a pre-hospital setting? Author-wise, like the people that wrote this was the British Paramedic Journal, like I said. These folks were generally involved more in like the health services of the UK and in the London area. They weren't necessarily physicians or nurses. There were a couple paramedics that were involved in the study. But again, just keeping in mind like the type of audience that put this together and how the study was run. And the question raised again is, in the absence of a retrospective scoring system, what considerations do pre-hospital care providers apply to defining major trauma? So to reword that, the question being raised is, without having a template in place that says if the vital signs are this is the type of designation, what are our pre-hospital experts saying, or what are they seeing that makes them identify something as a major trauma or as a minor trauma? The study design was basically using focus groups, which again is very subjective, right? You're basically talking to the participants and getting their perspective on something. There's no Likert scale. There's no hard number that they're giving. They're basically asking clinicians in the pre-hospital setting, as well as law enforcement, SWAT team, etc., what do they consider a major trauma? That is the whole study design. The main goal for this is that we're trying to look for trends specifically across the groups and see if there's any real agreement in terms of what defines a major trauma. One of the things they talked about when they were discussing the study design in general is they said that there's a particularly useful methodology for obtaining several perspectives about a topic and investigating collective understandings of the concept. So basically a bunch of words saying that basically we're going to listen to you talk about it, and we're going to look for trends, and we're going to lump them together. That's effectively what they're doing when they describe it as that. The other thing to keep in mind is that with this design, this is potentially generalizable to UK pre-hospital medicine, but may not apply to us in the US or in the rest of Europe or in Asia. This group is only looking at UK pre-hospital staff as well as law enforcement, etc. They talk about it being randomized in the sense that the study was open to everybody, but that's not necessarily true randomization, right? When we talk about randomization in a study, basically someone draws a number and you get assigned to that group. There's not necessarily just you volunteer and you go into the group. That's not really a true randomized. Their main argument is that since anyone could sign up for it, as long as they had a background in trauma settings, then they could be involved in the study. So that was their randomization piece in that case. The way they wound up doing that or getting people was using Facebook. and emails. So social media, some degree of randomization to it, but there is some selection bias there. Case in point, people that don't use email or people that don't use social media. So that's not necessarily a true randomized sample in that case. Biases, there's a long list of biases in this case, but some of the most relevant ones would be selection bias, who we're getting to participate in the study, as well as response bias. So we've got a bunch of pre-hospital people and we got law enforcement who are in a study that's asking about major trauma. So they now know what they're looking for, a specific answer. So you have that risk of someone trying to find the right answer to answer it correctly rather than give their honest opinion of it. So again, that's just some examples of biases that could impact this study. Inclusion and exclusion criteria, there wasn't really anything mentioned. When we talk about the actual methodology, how did they actually do this? How do we determine what major trauma is? They basically talked about, they did this, what they called a semi-structured interview. So basically they sat down 15 people in a group and they had some questions, but they didn't want to lead the group in any particular direction. So there were some questions to frame what they wanted answered, and then they let the group answer the questions openly. And then there was a recording and people would write it down. And what would happen is they would then code different phrases or themes that would recur while they were listening to the tape. They use what was called a data analysis framework approach. So apparently in the world of subjective data and economics, they've developed this system to better codify different phrases and stuff. And hopefully this makes the data more meaningful effectively. There's a lot of more mumbo jumbo to it. They have an entire journal article devoted to this. There's been people that have put a lot of effort into this, but how much it actually makes this data more meaningful, I don't necessarily know. I'm not necessarily trained in that area, but again, they're doing everything they can to try to really make this data meaningful, which I appreciated in this study in particular. When they were doing that actual framework approach and identifying the themes, they had two paramedics basically listening to it and identifying the themes. So they picked people that were the most trained and the most comfortable with major trauma so they could kind of pick out those elements. What did they actually find when they did this? They basically came up with three main themes. When they looked through the data, there were three themes related to major trauma they talked about. There was the clinician component, the patient component, as well as the situational factors of that trauma in question. So breaking that down further, when it came to clinicians, this is going to kind of make sense, right? The more experienced you are, the more you have your clinical gestalts built, the more comfortable and more confident you are in making that designation of this is truly a major trauma versus this is not. They also talked a little bit about logistics, your index of suspicion, meaning what does your clinical gestalt tell you based on what you're seeing? What is your training? What is your exposure taught you to make a good decision about is this a major trauma or not? And then the additional question of, based on the mechanism of injury, is there potential for further injury or progression of this pathophysiology to kill the patient? When we talk about patient factors, again, this is all factoring into what makes this a major trauma. The main thing they thought about was physiology. They talked about outcomes, which of these people were going to do really well, a 25-year-old versus the 93-year-old that fell and went boom, as well as pre-trauma factors. And when they're saying about that is, what are the patient's medical risk factors that you can obtain in that situation that further solidifies, is this going to be considered a major trauma versus not? When we talk about situational factors that they brought up, the main thing they're just trying to emphasize here is that every trauma is different. A car accident is going to be different in every different situation, whether there's 4 cars, 5 cars, is there a rollover, was there a fire in the car? Again, the situation is always going to change. Mechanism of injury is a factor, as well as the triaging ability. So big metropolitan area might have the ability to triage very effectively, whereas a smaller group that does not do mass casualty or does not deal with a lot of really bad car accidents or really bad traumas might not be able to make that triage as effectively. The main thing I want to take away from this is that it's complicated, right? Is it really doable for us in the field to make a major trauma designation versus a minor trauma designation? I'm going to say yes, but I'll explain why in a little bit. The main thing that they took away from this is those that are specialty trained, that are exposed to it a lot, are going to have better outcomes. This is kind of a given, right? The more you're exposed to something, the more you understand it, the better the outcome the patient is going to have. The other thing to keep in mind in this case is that the understanding of trauma has changed, and they're talking about in the UK, but I would argue this is true in the US, this is true anywhere. Your populations are aging. So what was originally a major trauma in an otherwise healthy 80-year-old is now more concerning for someone that's 80 now because they're on blood thinners or they're a diabetic that's uncontrolled. So all of a sudden they're falling and going boom could be a major trauma because of the fact they could have a massive intracerebral hemorrhage from hitting their head. That's something that they bring up that's important to keep in mind. They really emphasize the importance of having some form of triage checklist, whether that's on a national level or if that's going to be more regional or based on your hospital or based on your EMS service. The more tools that you have available, the better you can make the delineation of major trauma versus minor. The other thing that I think is really important to hit home, because I think a lot of people make this assumption, especially in rural settings, mechanism of injury is a very poor indicator of outcome. We just talked about the little elderly lady that falls and goes boom, and they're on a blood thinner. Hearing that is not a very serious mechanism of injury. But if you take in the other factors, clinical comorbidities, mechanism, what blood thinner they're on, this suddenly becomes a lot more apparent that it could be a major trauma. So the main purpose I brought this article up is that I really want to shift our opinions of that. We can't just base this on, this is a really bad car accident, we need to auto launch. We should be thinking more in the context of how old is the patient? Are they awake enough to tell me a little bit about their medical history? And do we need to auto launch based on that rather than just assuming that the car is twisted and on fire? That necessitates a major trauma activation. Like, that's kind of an obvious thing, but we need to think more about the gray areas. Limitation wise, because again, when we do journal review, we want to make sure we identify the limitations of the study. So limitations in this case is that this is a single trauma network in the UK. I think it was in London in particular. The focus groups, again, we talked about that there's a very high risk of bias in that case. This is subjective data, so we aren't getting any hard numbers. This is just based on people's perspective, which is important. We obviously want to get perspectives from everyone that's involved in trauma management, but it can lead to bias in that case. We also have the issue of perspective, right? So the less experienced you are, the less able you are to really give a good assessment on a trauma or not. So that was one of the other limitations I talked about. Big takeaways. So major trauma is going to be unique to every provider, every patient, and every situation. And it requires basically an on-the-fly assessment plan, right? You got to be able to adjust to your strategy and identify things that might change the algorithm to expedite transport. Mechanism of injury can cloud the clinical picture. I think we've kind of hammered that home enough to make that point very clear. And they did throw out a definition, which I thought was something worth thinking about. But this is, again, a discussion that you would probably need to have with your ambulance services, with your facilities that receive your patients, et cetera. They came down to it for a conclusion is any injury or injuries that have the potential to be life-threatening or life-changing. Important point there, right? If we've limb-threatening, for example, including those sustained from low-energy mechanisms in people rendered vulnerable by extremes of age. So, little kids to elderly population. Comorbidities or frailty, resulting in significant physiologic compromise, so whether that's hemodynamic, brain injuries, respiratory compromise, and or significant anatomical abnormality that may require immediate intervention. I think that's a much cleaner definition where you can actually work with it a little bit more compared to how gnarly does the car look. Not a lot of objective data. There's not a t-test. There's no way to determine the clinical significance of this. But I think it does open some really good questions, especially for those of us in the rural setting or in the austere medicine setting, to really think about what does major trauma mean to us so that we can provide better outcomes for our patients. I wanted to talk a little bit about burn management and what the current consensus is. I'm going to walk through some recommendations, and this is a study out of the UK titled Consensus on the Prehospital Approach to Burn Patient Management. There is not a lot out there for prehospital management. I figured it'd be good to just talk about it in this case and just really kind of work our way through it, and then I'll throw in the examples related to our patient just so we can kind of think about it a little bit more clearly. This was done in 2004. I could not find any follow-up studies related to prehospital burns after that when I was looking. And this is in the Emergency Medicine Journal. And this is the only relevant study that I could find after I spent like an hour or two looking for this. And this is the only one that I thought that was really applicable to us in the field. And so basically, this is just discussing some steps based on several UK expert opinions. So they have like a burn group. They've got their surgeon teams. A couple other Royal Colleges put their opinions in as well. So this is basically a synopsis of kind of the important things you want to think about in the context of a burn injury or a trauma burn. They talk about what's called the SAFE approach. So we talked about environment a little bit already. Shouting for help, assessing the scene, making sure that you are free from danger, and then evaluate the casualty in question. All that really just kind of hammers home that, is the scene safe? Are we able to proceed safely? Can we get the patient extracted without any injury to the patient or ourselves? A lot of these things are kind of duh, but you really need to think about this a little bit. Obviously, step one when you get to the scene is stop the burning process. So if this patient is still on fire, step one is putting out said fire. There's a couple ways we can do that. But the important thing is that we're going to extinguish it in some shape or form. I'm hoping that at this point fire has arrived or that someone has like a blanket that can suppress the burn or the flames or whatever. But then once that's done, clothing, you got to get that off as soon as you can so it doesn't adhere to the skin. And then you want to decontaminate the patient as well if it's applicable. So if this is like a pesticide or this is a farming injury, you don't know what else is there. So you have to assume toxins. So you want to make sure that the patient is decontaminated before you put them into an ambulance, because if this is something that could be anticholinergic, all of a sudden you have 3 patients in the back of the rig because they've inhaled pesticide in an enclosed space for an extended period of time. Keeping that in mind, that not only could this be a burn from gasoline, this could be a burn from a farming injury, which is much more common for us in the rural settings. Cooling. I thought this was a very good phrase of it. We want to cool the burn wound, but we want to keep the patient warm. Any burn areas that we see, we want to make sure that we apply dressings that are cool and try to get that area cooled down. But at the same time, we don't want the patient to start shivering. So we've got to figure out a balance of getting those burns themselves cooled down, but keeping the patient warm. Some examples of covering and dressing in this case is that, one, we got to make sure the wounds are as clean as they can be. I mean, you don't need to sit there and like pick out all the grass or everything like that. But if you can get the wound cleaned out and get it covered, that's an important first step. They talk about cellophane wrap a lot. It's just a good way to protect the wound. Once you get it cleaned out, you can wrap it. But if it's one of those circumferential burns where it's all the way around, you risk restriction of blood flow. So you don't want to necessarily do it in that case. And if you are going to do it, making sure that it's loose enough that you're not going to be causing constriction. And then keeping the patient warm with a blanket. So we had talked about exposing the patient in our example. So once we've exposed them, found all the areas that are burned, treated them, that patient needs to be covered up with a warm blanket of some kind. With burns, you're going to lose body heat really quickly. So we've got to try to help find ways to retain body heat when we can. Airway assessment. So they talk about the ACBC, which basically just means airway, cervical spine, breathing, and circulation/cannulation. So we've kind of belabored that one already, so I don't think we need to talk about that any longer. Talking about the assessment of burn severity, this will be a whole nother topic at another time. But there's things like the rules of nines. There's other ways that we can quickly assess. But this just kind of helps us start to think about fluid resuscitation. But in the context of trauma in pre-hospital, we're not going to muck around and try to calculate that. That's something more meant for the hospital. And if you're needing to do additional fluids, you can always call ahead and ask questions in that case. Other things that we want to keep in mind is that we want to make sure we figure out how severe the burn is. So we want to know the time of the burn injury. We want to know the mechanism of injury. So if this person dumped gasoline on the fire and exploded in their face, that's your mechanism in that case. Is there an inhalational component, which we identified in our example? And then if they're children or elderly, is this potentially a non-accidental trauma scenario? So was the kid pushed into the fire? Was an elder put in scalding hot water and left there for hours at a time? These are questions you're going to have to ask for extremes of age. Cannulation. So when we're talking about getting access, you've got to be quick. If we are not successful with 2 IV sticks is their recommendation, you go to IO and you go. And if you can't get the IO to work, you go regardless. You can worry about fluids later, because definitive care is going to be getting them somewhere where we can cannulate them and get fluids and blood products started if we need to. Generally speaking, if you're going to do a bolus, it's going to take you an hour for that bolus to go in. So hopefully by that point, you're at your facility. So rule of thumb would be, if it's an adult, start a liter of fluid, get them to the nearest level of care. If it's a 10-year-old or older, up to like maybe 15, 16, maybe do a 500 cc bolus. If they're 5 to 10, maybe a 250 cc bolus. Or if they're younger, you probably just hold it, just because there's a high risk for fluid overload in that case. And hopefully you can get the kid there quickly. Again, these guidelines are from like 2004. Some of these things could change. And if anyone hears this and disagrees, please let us know and we can certainly update this recommendation. But I think it's a good rule of thumb for rural medicine, just because for those of us that are doing rural pre-hospital care, we don't have the ability to do those calculators quickly. So this is a quick and easy, safe way to start fluid resuscitation in a patient that has a burn. Pain control, super, super important for patients. Once you've got an IV in place, we're going to want to give them something. And burns hurt. Whatever you've got in the rig, if it's fentanyl, if you've got Dilaudid, if you've got morphine, you got ketamine, like use whatever your protocol dictates, but burns hurt a lot. And so we need to make sure that pain control is met en route, because it's going to be terrible the entire time. If we're going to be giving pain meds, again, you got to use your judgment for airway. Obviously patients can start to desat, they can get drowsy, and that could muddy the waters a little bit as well. So you got to be a little bit aware if you're going to start doing that. Transport, load and go. Very simple. There's not any like official like numbers or data here, but it's just a good discussion point to have for those of us that don't see burns very often. I think those are some very quick and easy common sense things to think about when you see burn injuries. We'll probably have another burn example in the future during one of our quick hits, and we can talk more about burn assessment, what different types of burns are, and how we would treat them. Let's go back to the protocol itself. Regan, do you want to unpack how we would approach this scenario?
We've talked about it a lot with this March's mnemonic, and that is how the protocol is laid out as well. If we keep it simple, we keep that repetition, when we get into these high stress, high anxiety, my heart rate's higher than the patient's, we know that we need to just go back and be like, okay, are they bleeding? Fix that. Do they have an airway? Fix that. Are they actually breathing? Let's fix that. Do I have fluids running? Can I get an attempt going? Let's do that. Do we have a head injury? What is even going on there? Are we in an okay environment? Have they been stripped of their clothing? All of these things that we've talked about through our case, through our pathophys, through our treatment, that's what's written into that protocol. And with these protocols, you are not looking these up out in the field. You are not stopping to be like, oh yeah, what was E again? Can't quite remember that. You're going to keep thinking about this. You're going to have scenarios about this either in podcasts that you listen to, in practice runs with your crew, or even running through a truck check. You can be like, okay, here's my hemorrhage kit. Man, I should keep this close for a trauma. What was that again? Marches? Okay, run back through it. So again, when you get to these scenarios, this protocol is just in the back of your mind. It's as simple to you as your mind saying, inhale and exhale. Additionally, within our protocol, we talk a little bit about pain management, going specifically with our service area, some of the medications that we can use. It'll be different for what you have on your rigs. So just be sure that you keep in mind that these patients are in pain, whether conscious or unconscious, and keep in mind that we got to treat that as well. Handle the life-threatening things and continue to keep our patients comfortable, because the experience that they're having is already probably one of the worst in their lives. We don't need to make it worse for them.
And now that we've got a website up and running, we will actually upload our protocol example for you all to review. Obviously, each agency's setup is different, but we just like to put that out there so that people can process and think through it as well. So if there are questions or arguments about what might be a better way to frame it, obviously we welcome those types of discussions, because pre-hospital medicine is a more of an art form than a science, and we want to make sure that we're doing the best we can for patients every single time. We've talked about pathophys. We've talked about the literature, which got a little bit long. I apologize, but I thought it was a very interesting topic. We talked about basically how to treat, going back to this case, Regan, how we would treat this patient. To recap, this patient unfortunately decided to dump some gasoline on a bonfire. It exploded in their face, sustaining severe burns to their face, to their airway, to the chest, to the arms, with some sparing to the legs. You hear some sounds of stridor. You got concerns about airway compromise. Let's walk through a little bit what you would do to keep this patient alive to definitive care.
So like we talked about at the beginning, it's all about looking at your patient, seeing a problem, and fixing it. In this case, we didn't see any hemorrhage. We're not worried about that, but we know that we have airway difficulties. Our patient is able to make some noises, maybe is responding to us, but I don't think an airway adjunct is going to do the thing here. I'm going to move more towards an intubation. If I can't get that on the first pass, I want to get a supraglottic airway in there. We want to make sure that we have all of our equipment close by. So since I have heard from dispatch that this is a gas explosion, I'm kind of thinking worst case scenario. I'm making sure that my go bag has my intubation equipment in and close. If not, I'm even grabbing it real quick while my partner has other gear. I want to keep that right next to me. And I want to keep backups next to me as well. If I'm going with even with a bougie and I'm not quite getting this, I'm not going to sit there and wait for my partner to run back to the truck to grab the next piece of equipment. We want to keep in mind what can go wrong and have it next to us. So hopefully we get this airway on our first pass. We're going to get air moving through here, whether with a BVM or at this point trying to get it into the back of the rig and hooking them up to our ventilators. Anything to get that air moving, as well as getting some circulation, whether myself after intubating or my partner, or even some of the EMTs or paramedics that might be on fire as well. Do not be afraid to ask for help. Can be getting access, whether IV. Maybe that doesn't go well the first 2 times, so we throw in an IO, and we're trying to keep all of this moving quickly so that we can get into the back of the rig and get going.
And when you do your IO placement, Regan, where do you not go?
Probably not anywhere that's burned.
Correct.
You want to You want to stick to something that can be easily accessed but isn't already compromised. And luckily, in this patient, our lower half of the body is pretty untouched. So we can do that standard anterior tibial there.
Yep. Big toe IO. That's how I always remember it. And it's a good spot to go. So we'll say the IO is in. You effortlessly intubate this patient after listening very diligently to the episode 4 RSI podcast and had all this wonderful knowledge to put the patient to sleep comfortably and paralyze them. So you successfully passed the tube in. O2 sats have improved. Respirers are still a little fast at 30, but saturations are closer to like 96, 97%.
So we're feeling a little bit better. We're still packing up, we're going quickly, and as we're getting into the back of the rig, we of course have our radios back there. We're considering where we're going, how fast we're going, and what we are telling our crews in the hospitals. My driver knows we're probably code 3, lights and sirens, whatever your service area calls it, given that we have a pretty critical patient here. And where we're going really is going to depend on our location. If we're way out in the sticks, like many of our listeners are, we're going to the closest facility. Yes, we have a burn patient. I'm not driving the extra 4 hours to get to the burn center when I could have been at a hospital in 45 minutes. We're going to get to that closest access of that next level of care before we can schedule a transport to get to the next facility. I'm also calling them to tell them what I have, keeping it short but full of information so that they're prepared for what's coming in their doors. I don't need to give them the perfect rule of 9s of how many burns are going on, but I'm going to let them know probably half the body here. We have a fluids running, we have an airway, and we're about 30, 40 minutes out. And we can always call and update them whenever anything changes in the back. But as soon as we get back there, we need to know where we're going and who's going to pick us up.
And that's an important point. You want to be clear and concise, but you want to give enough detail so that if I'm the physician at the local ER hearing this page go out, then I'm telling my support staff, I want a helicopter in the air 20 minutes ago. So that by the time you're here, the helicopter's already landed. The paramedic that's going to fly with the flight nurse is ready to go. They've got the context. And if we need to do some stabilization, we will. And if not, they go right into the back of the helicopter and away they go to definitive care. Because obviously definitive care is going to be a place where there's a burn unit, some burn surgeons, like if there needs to be grafting, like that's all stuff that we can't do there. So as long as the patient is stable, then we can move on. So I would say that with you intubating the patient, the O2 sats are holding, respirators are still a little bit high, but the airway is definitively protected. With your liter of fluids, the heart rate's probably improved to like maybe 115, 120, pressure's holding at like 100 systolic. So best you can tell on that information, this patient's probably not hemorrhaging. But as you alluded to earlier, anytime that there is an explosion of some kind, concussive force can cause trauma. And I forget, there's like primary, secondary, tertiary, quaternary. I think there's a 5th degree that you can have of concussive injuries. I'm not going to go through them all right now. But the important thing to keep in mind is that anything that has a membrane can get damaged. So their TMs can be blown. Viscera can tear and start to bleed or have bowel contents go into the abdomen. Fractures can happen. Like these are all important things and why we really need to assess the patient carefully, because anything that can be reversed in the field should be, or at least intervention should be started so that the patient is optimized by the time they get to the nearest hospital.
And this is where that secondary assessment and the back of the rig comes in. Probably a secondary to your secondary. You're just going to keep reassessing this patient, see if you found something new. Especially with burns, they can be very distracting, even to clinicians. It's kind of the first thing you see, and it sometimes is hard to get your mind going and thinking, did they also fracture a limb and that I didn't splint? Or you want to make sure that you keep thinking of all of the and this scenarios. So keep reassessing your patient. Of course, every time you do an intervention, you're going back through head to toe, getting a nice reassessment in there.
And that's why things like marches is so helpful, because if you feel like you're stuck in the leaves and a patient suddenly becomes hypotensive, you go right back to your march and you walk yourself through it mentally so you don't get lost and you don't miss the things that could kill the patient. Like you said, burns are very challenging and we don't see a lot of them in rural settings. But I think something that's very important in this context, and I've said it already, is that you have to keep the human element in mind here, because burns hurt. even if it's just like a first-degree burn, like they hurt badly. And the deeper you go down, the more painful it is until you burn through nerves and bone. Then that's painless, but that's a different discussion for another day. If a patient is having pain, treat the pain. If you've driven 35 minutes or an hour and you haven't given them anything for pain, then you did your job wrong. We got to make sure the patient is comfortable so that we can do a better assessment, and we can probably get some more meaningful information out of the patient if they're not so distracted by their 12 out of 10 or their 100 out of 10 pain because their skin is effectively sloughing off. Just an important thing to keep in mind in that case. And with that, we come to the conclusion of another exciting episode. We're going to be doing some trauma cases throughout the summer. We're going to call it our quick hits episodes. And we'll talk about a case and just really focus more on the March's mnemonics, the finer nuances of those specific trauma injuries in question. I'm very excited that we're going to be talking about point of care ultrasound in pre-hospital setting with a friend of mine here in the near future. It's going to be a very interesting discussion. I really hope it stirs the hornet's nest a little bit and brings up some discussion because I think it is something that's very important in this field. And we'll also be getting some perspectives from Eastern Europe and their EMS services. So it's going to be a very interesting couple months here going into the summer, and I'm excited about it. And with that, may your mayhem be well controlled, full of teachable opportunities, but also provide you with the opportunity to provide your patients with the best care possible.